Hello, I'm Dr. Nasmani and this is the continuation of the tutorial on ECG. So we stopped with the localization of the site of infarction in the previous video. For continuation purpose, I will start from there. The distribution of changes recorded in acute myocardial infarction allows the area of infarction to be localized. Thus, the site of arterial disease can be localized. Proximal arterial occlusions tend to produce the most widespread electrocardiographic abnormality. The anterior and inferior aspects of the heart are the areas most commonly subject to infarction. Anteroseptal infarcts are highly specific indicators of the disease of left anterior descending artery. Isolated inferior infarcts, changes in the lead 2, 3 and AVF are showing in isolated inferior infarct, and it is usually associated with the disease in the right coronary or distal circumflex artery. The disease in the proximal circumflex artery is associated with the lateral infarct pattern, and that will be shown in lead 1, AVL, V5 and V6. So the sum up, this anatomical relationship of the leads are shown in this figure. Inferior wall, you will look for changes in lead 2, 3 and AVF. Anterior wall, changes are seen in V1, 2, 3, 4 leads. Lateral wall, the changes are seen in lead 1, AVL, V5 and V6. Suppose you are looking at the non-standard leads, the right ventricular infarction can be located in the chest leads V1R to V6R. That means you have to especially ask the ECG technician to take such ECG recording. And then posterior wall infarction, if you want to diagnose, you have to take special leads V7, V8 and V9. So this anatomical relationship of leads is an important thing, and especially asking for extra leads. Now the right ventricular infarction needs some attention. Right ventricular infarction is often overlooked as standard 12-lead ECG is not particularly sensitive indicator of right ventricular damage. Right ventricular infarction is associated with 40% of inferior infarction. It may also complicate some anterior infarction, but rarely occurs as an isolated phenomenon. On the standard 12-lead ECG, right ventricular infarction is indicated by signs of inferior infarction associated with ST segment elevation in lead V1. It is unusual for ST segment elevation in lead V1 to occur as an isolated phenomenon. Right-sided chest leads are much more sensitive to the presence of right ventricular infarction. Most useful lead is lead V4R. That's an electrode is placed over the right fifth intercostal space in the mid-clavicular line. Just like you got the V4 on the left side, here you are placing on right mid-clavicular line. Lead V4R should be recorded as soon as possible in all patients with inferior infarction, as ST segment elevation in right ventricular infarction may be short-lived. So whenever you suspect MI, always take ECG in the special leads also. That's a lesson. So this picture shows the placement of right sided chest leads V2R, V3R, V4R, V5R and V6R. Just like you place your left side lead, only thing the letter R shows that the leads are placed on the right side. Such special leads are taken also for dextrocardia and dextro position. Acute inferior wall infarction with associated right ventricular infarction is shown in this picture. So please go through this picture carefully. I will show this for some more time for you to memorize. These video streamings are followed by exercise also. So repeated playing of such videos through YouTube is essential for you to keep your memory intact. This picture shows acute inferior myocardial infarction with the right ventricular involvement. Another example of acute inferior myocardial infarction with the right ventricular involvement. So this picture also needs you to memorize the picture. There is a pattern in all these ECGs, so try to memorize those patterns about which the principles I have already showed you. Only thing is that the lead names need some attention. So when you are given a ECG, please look at the names. Okay, for example, here V1R, V2R, V3R, V4R, V5R and V6R are shown. So that means the right ventricular involvement. So if you don't look at the ECG lead name, you may miss it. You may recognize the waves. The diagnosis of right ventricular infarction is important as it may be associated with hypotension. That's an important thing. Treatment with nitrates or diuretics may compound the hypotension, though the patient may respond to fluid challenge. So it is one of the rarest situations where you give IV fluid in a person who comes with myocardial infarction. So that's important thing, and people have died just because the attending doctor has missed it. Right ventricular infarction usually results from occlusion of the right coronary artery proximal to the right ventricular marginal branches, hence it is association with the inferior infarction. Less commonly, right ventricular infarction is associated with occlusion of the circumflex artery, and if this vessel is dominant, there may be an associated inferolateral wall infarction. Now this picture shows the position of V7, V8 and V9 on the posterior chest wall below the inferior angle of the scapula from lateral to medial. The positioning 7, 8 and 9. Posterior wall infarction. Posterior myocardial infarction refers to infarction of the posterior-basal wall of the left ventricle. The diagnosis is often missed as the standard 12-lead electrocardiography does not include posterior leads. Early detection is important as thrombolytic treatment may improve the outcome for patients with posterior infarction. So one thing I told in the beginning was the right ventricle, and the second thing I am telling here is the posterior infarction. These two are likely to be missed, especially if you are in a emergency setup and early morning 4 o'clock to 8 o'clock. The duty doctor also may be on the verge of going home, so ECG reading may be missed, so please take care. The changes of posterior myocardial infarction are seen indirectly in the anterior precordial leads. Lead V1 to V3 face the endocardial surface of the posterior wall of the left ventricle. As these leads record from the opposite side of the heart instead of directly over the infarct, the changes of posterior infarction are reversed in these leads. The R waves increase in size, becoming broader and dominant, and are associated with ST depression and upright T waves. This contrasts with the Q wave, ST segment elevation and T wave inversion seen in acute anterior myocardial infarction. Acute anterior myocardial infarction. Ischemia of the anterior wall of the left ventricle also produces ST segment depression in leads. V1 to V3, and this must be differentiated from posterior myocardial infarction. Ischemia of the anterior wall of the left ventricle also produces ST segment depression in the leads V1 to V3, and this must be differentiated from posterior myocardial infarction. The use of posterior lead V789 will show ST segment elevation in patients with posterior infarction. These additional leads therefore provide valuable information. They help in identifying the patients who may benefit from urgent reperfusion therapy. And this picture shows the ST segment elevation in the posterior leads V8 and V9. This picture shows the isolated posterior infarction with no associated inferior changes. Now this T segment depression lead V1 to V3. Long-standing ST segment elevation and T-wave inversion associated with a previous anterior infarction is shown in this picture. Electrocardiography shows a left ventricular aneurysm. And this picture shows the hyperacute T waves. So the indicators for thrombolytic treatment are ST elevation more than 1 milliliter into contiguous limb leads or more than 2 millimeter into contiguous chest leads, posterior myocardial infarction, then left bundle branch block. ST segment depression or enzymatic changes are not indications for thrombolytic treatment. The ECG tutorial continues in the site www.youtube.com/acpgmed, and the links also will be provided in the facebook.com acpgmed. Thank you.